Two types, loops and scalars. The ones that we've seen so far in the lab have been the scalars, and we'll learn more about them and their use at the bedside. But now we're going to learn a little bit about loops, in particular the pressure volume loop. Here are three types of pressure volume loops in three different situations. The first one is in spontaneous breathing. And as you see, this is your pressure here, and this is your volume here. During a spontaneous breath, when the pressure in the thorax becomes negative, the inspiration begins and volume fills into the lungs until it becomes 0 and then slightly positive for exhalation. In this model, we can see that there has been a negative deflection prior to inspiration, which is positive pressure. So this would be what mode? Yes, assist control, where the patient assisted the breath and then the ventilator responded by delivering either the set pressure or tidal volume and then cycled into exhalation. In this model, you can see that we have controlled ventilation. This is inspiration and expiration, but there's no negative deflection here. So that one was not patient initiated. Now, we can tell a lot of things by looking at these loops. This is a normal condition in the middle here, but you can see that the graphic, the loop starts to lay down or go to the right as the compliance decreases, showing you that it's taking more pressure to get in that volume. As you can see, this would be the PIP for the patient with the low compliance versus the PIP for the patient with normal compliance. And then the opposite is true for patients that have increased compliance. The PIP is less, it takes less pressure to deliver the same amount of volume. The other things that we can tell from a pressure volume loop is we can see that the alveoli respond at a certain point, that there isn't much volume delivered for the same increase in pressure until it reaches a certain point. Then we get a lot of increase in volume for the pressure, and then up here again we see that there is no change in volume, but yet the pressure is increased. So for this point, we call this the lower inflection point, and this represents a critical opening pressure for the alveoli. It would be the desirable place to set your PEEP level, as the alveoli are in a position to now receive volume. The volume goes in, and up here we see that we're getting no change in volume, but we are just adding pressure. So therefore, this would be the optimal place to set the end of your tidal volume or the end of your pressure if you were in pressure control ventilation. So this is referred to as the lower inflection point, and this one is the upper inflection point. If the lower inflection point is not used to set the PEEP level, then what happens is the repeated opening of the alveoli causes atelectrauma. The reverse is true. If the delivered breath continues to go without much change at all in volume, then this would cause volutrauma. Both of these should be avoided. And so this graphic is very useful at the bedside for determining these levels. You must be aware that these readings need to be taken during a square flow pattern. It needs to be a constant flow generating the waveform that you're looking at, or the loop that you're looking at, in order to make those decisions, because varying the flow pattern will have changes in the loop. There's a lot of information that we can gather at the bedside from these ventilator graphics, but I'm not so sure we can tell if the patient wants to watch the football game or not.